Hello class, welcome to Chapter 30, Abdominal and Genitourinary Injuries. After students complete this chapter and the related course route, they will understand how to manage a patient with abdominal and genitourinary trauma. The student will learn how to recognize life threats associated with these injuries and the need for immediate intervention. The curriculum includes detailed anatomy and physiology of the abdominal and genitourinary systems, as well as the pathophysiology, complications, assessment, and management of abdominal and genitourinary injuries. The assessment section is very comprehensive and follows the primary and secondary model. Specific injuries discussed include blunt versus penetrating mechanisms, evisceration, impaled object, injuries to external genitalia, vaginal bleeding secondary to trauma, and sexual assault. Emergency care skills including management of blunt abdominal injury, penetrating abdominal injury, and abdominal evisceration. Introduction. The abdomen is the major body cavity extending from the diaphragm to the pelvis. It contains the organs that make up the digestive, urinary, and genitourinary systems. It is important for the EMT to know the anatomy of the abdominal and pelvic cavities and where organs are located. Understand the functions of the organs so you can assess an injury's seriousness. Significant trauma to the abdomen can occur from blunt trauma, penetrating trauma, or both. Injuries to the abdomen that go unrecognized and are not repaired in surgery are a leading cause of traumatic death. 10% of all trauma patients have some form of genitourinary tract injury. Anatomy and physiology of the abdomen. Abdominal quadrants. The abdomen is divided into 4 quadrants. The quadrant location of bruising or pain can delineate which organs are possibly involved in the traumatic injury. Organs commonly found in the right upper quadrant: liver, gallbladder, the duodenum of the intestines, and a small portion of the pancreas. Organs found in the left upper quadrant: stomach and spleen. Organs found in the left lower quadrant: the descending colon and the left half of the transverse colon. Organs found in the right lower quadrant: large and small intestines, the ascending colon, and the right half of the transverse colon and the appendix. The right lower quadrant is a common location for swelling and inflammation. The appendix is a source of infection and can cause severe infection or septic shock if it ruptures. Hollow and solid organs. The abdomen contains hollow and solid organs. The hollow organs of the abdomen include the stomach, intestines, ureters, and bladder. Most of these organs contain food that is in the process of being digested, urine that is being passed to the bladder for release, or bile. When ruptured or lacerated, the contents spill into the peritoneal cavity, can cause an intense inflammatory reaction and possible infection. Peritonitis is an inflammation of this type. Serious and may become life-threatening. Signs include severe abdominal pain, tenderness, and muscular spasm. Intestinal blood supply comes from the masseter, fold of tissue that connects the small intestine to the abdominal wall. Patients with injuries to the masseter can bleed significantly into the peritoneal cavity. Signs of this include abdominal rigidity and para-umbilical bruising. These figures show the hollow organs and the solid organs of the abdomen. The solid organs of the abdomen include the liver, spleen, pancreas, and kidneys. These organs perform the chemical work of the body. enzyme production, blood cleaning, energy production. Because of their rich blood supply, hemorrhage of solid organs can be severe. Injuries to the abdomen. Abdominal injuries are considered either open or closed and can involve hollow and/or solid organs. Closed abdominal injuries. Blunt trauma to the abdomen without breaking the skin. Some MOI examples: steering wheel, bicycle handlebars, motorcycle collisions, falls, blast injuries, pedestrian injuries. Compression. Typically caused by a poorly placed lap belt, creates an injury pattern called a clasp knife injury. Can also be caused when a person is run or rolled over by vehicles or objects. Deceleration. Person or the vehicle that he or she is traveling in strikes a large, immovable mass, such as a larger vehicle, a bridge, ambulance, or the ground. Signs and symptoms of a closed injury. Pain can be deceiving, often diffused in nature, may be referred to another body location. Liver and spleen injuries refer pain to the shoulder. Tearing pain from the abdomen posterior may be a dissected aneurysm. Pain following the angle from lateral hip to midline of the groin can be the result of damage to the kidneys or ureters. Pain located in the right lower quadrant can indicate an inflamed or ruptured appendix. Pain under the margin of the ribs on the right side or between the shoulder blades can indicate an injury to the gallbladder. Blood or fluid in the peritoneal cavity produces acute pain in the entire abdomen. Pain spreads as blood or a contaminant seeks out the voids in the peritoneal cavity. Often a jarring motion, rebound tenderness, or a Bloomberg sign will alert the patient to the peritonitis or inflammation of the peritoneum. Determine the location of the pain or referred pain can be difficult when the patient has voluntary or involuntary guarding. Conscious or unintentional stiffening of the muscles of the surface of the abdomen to avoid further pain may be mistaken for abdominal rigidity. Abdominal distension or swelling between the xiphoid process and the groin is often the result of free fluid, blood, or organ content spilling into the peritoneal cavity. Additional signs of abdominal injury are bruising and discoloration. Closed abdominal injuries may initially appear as abrasions. Injuries from seatbelts and airbags. Seatbelts have prevented many injuries and saved many lives, but they occasionally cause blunt injuries to the abdominal organs. When worn properly, a seatbelt lies below the anterior superior iliac spines of the pelvis against the hip joints. If the belt lies too high, it can squeeze abdominal organs or great vessels against the spine when the car decelerates or stops. Can cause bladder injuries to pregnant patients who adjust the lap belt for comfort. In all current model vehicles, lap and diagonal belts are combined so they cannot be used independently. People can still put the shoulder belt behind their backs. These figures show the correct and incorrect placement of a seatbelt. Open abdominal injuries. Injuries in which a foreign object enters the abdomen and opens the peritoneal cavity to the outside, also called penetrating injuries. Stab wounds and gunshot wounds are examples. Open wounds can be deceiving, therefore you should maintain a high index of suspicion for unseen injuries, internal damage to organs, and possible life-threatening injuries. The velocity of an object can help predict the amount of damage to the tissue. Low-velocity injuries caused by handheld or hand-powered objects, such as knives or other edged weapons. Medium-velocity injuries caused by small-caliber handguns and shotguns. High-velocity injuries caused by larger weapons, such as high-powered rifles or high-powered handguns. High and medium velocity injuries have temporary wound channels in addition to exit and entrance wounds caused by cavitation. A cavity forms as the pressure wave from the projectile is transferred to the tissues, causes microscopic tears to blood vessels and nerves, can produce a large amount of bleeding. The higher the velocity of the projectile, the larger the cavity it produces. Low velocity penetrations also have the capacity to damage underlying organs. Internal injury may not be apparent during physical examination. Bleeding may hide the fact that the object went further and deeper into the peritoneal cavity and injured other organs and tissues. Anytime a patient has an injury at or below the xiphoid process, it should be assumed that the thoracic and peritoneal cavities have been violated. An evisceration. Bowel protrudes from the peritoneum. This can be extremely painful and also visually shocking. Do not push down on the patient's abdomen. Only perform a visual assessment when there is any suspicion of this type of injury. Cut clothing close to the wound. Never pull on any clothing stuck to or in the wound channel. Signs and symptoms of an open injury. Patients with abdominal injury complain of pain. Common sign of significant abdominal injury is tachycardia. The heart is increasing its pumping action to compensate for blood loss. Later signs include evidence of shock, such as decreased blood pressure and pale, cool, moist skin, changes in the patient's mental status. Abdomen may become distended from accumulation of blood and fluid. A patient may have both closed and open injuries. Blunt injuries should guide your attention to the underlying structures. Bruising in the right upper quadrant may suggest injury to the liver. Bruising in the lower left upper quadrant may suggest injury to the spleen. Bruises to the flank may suggest injury to kidneys. Bruising around the umbilicus, called a Cullen's sign, are predictive of significant internal bleeding. Hollow organ injuries often have a delayed signs and symptoms. Hollow organs commonly spill contents into the abdomen. Infection develops, which can take hours or days. Stomach and intestines can leak highly toxic, acidic digestive liquids into the peritoneal cavity. Both blunt and penetrating trauma can cause hollow organ injury. Blunt trauma causes the organ to pop, releasing fluids and air. Penetrating trauma causes direct injuries such as lacerations and punctures. The gallbladder and urinary bladder are hollow organs which contains bile and urine, are potentially irritating and damaging if ruptured. These fluids move into loose spaces and voids in the peritoneal cavity, eventually leading to infection. Free air in the peritoneal cavity produces pain. Usually intestines that are a hollow organ or loop of bowel has perforated. If not rapidly identified and repaired, severe infection and septic shock may develop. Solid organ injuries. Solid organs can bleed significantly and cause rapid blood loss. Can be hard to identify from a physical examination because the patient is not experiencing significant pain. Solid organs can also slowly ooze blood into the peritoneal cavity, causing pain to increase slowly over time. The liver is the largest organ in the abdomen, very muscular and can contribute to hypoperfusion if injured, often injured by a fractured lower right rib or penetrating trauma. A common finding during assessment of patients with an injured liver is referred pain to the right shoulder. The spleen and pancreas are also very vascular. Both are prone to heavy bleeding when fractured, lacerated, or punctured. The spleen is often injured from motor vehicle collisions, especially in cases of improperly placed seatbelts, steering wheel trauma, falls from heights or onto sharp objects, bicycle and motorcycle accidents where the patient hits the handlebars on impact. If the diaphragm is penetrated or ruptured, loops of bowels may urinate into the thoracic cavity. Patients may exhibit dyspnea, feel short of breath. The kidneys can also be impacted or penetrated by trauma, can cause significant amounts of blood loss. Common finding is blood in the urine. Blood visible on inspection of urinary mentis indicates significant trauma to the genitourinary system. Patient assessment of abdominal injuries. Assessment of abdominal injuries is one of the most difficult assessments that you will perform. Causes of injury may be apparent, but resulting tissue damage may not be so apparent. Patient may be overwhelmed with other more painful injuries. Some abdominal injuries develop and worsen over time, making reassessment critical. Scene size up. Standard precautions should be taken at the scene. Gloves and eye protection should be a minimum. Be sure the scene is safe for you. Call for additional resources early if needed. Mechanism of injury, nature of illness. Observe the scene for early indicators of the MOI. Consider early spinal precautions. Consider all of the injuries the MOI could have produced. Primary assessment. First, perform a rapid scan. Will help establish the seriousness of the patient's condition. Some abdominal injuries will be obvious and graphic, but most will be very subtle and will go unnoticed. Remember that in some cases of abdominal injury, the injury may have occurred hours or days earlier. Form a general impression. Important indicators will alert you to the seriousness of the patient's condition. Trauma patients with closed abdominal injuries may have what appear to be minor injuries. You should not be distracted from looking for more serious hidden injuries. Check for responsiveness using the AVPU scale. Provide high-flow oxygen via non-rebreather mask to all patients whose level of consciousness is less than an alert and oriented. Unresponsiveness may indicate a life-threatening condition. In trauma patients, life-threatening external hemorrhage must be addressed before airway and breathing concerns. Airway and breathing ensure that the patient has a clear and patent airway. If a spinal injury is suspected, prevent the patient from moving. Clear the airway of vomitus so it is not aspirated into the lungs. Note the nature of the vomitus. A distended abdomen may prevent adequate inhalation. Providing supplemental oxygen will help improve oxygenation. Circulation. Superficial abdominal injuries usually do not produce significant external bleeding. Internal bleeding can be profound. Trauma to the liver, kidneys, and spleen can cause significant internal bleeding. Evaluate pulse, skin color, temperature, and condition to determine the stage of shock. Treat aggressively if the patient is in shock. Transport decision. Abdominal injuries generally indicate a quick transport to the hospital. A delay in medical evaluation may result in an unnecessary and dangerous progression of shock. Patients with abdominal injuries should be evaluated at the highest level of trauma center available. History taking. Clarify the chief complaint and MOI. Also identify associated signs and symptoms and pertinent negatives. Note the position in which the patient is lying. Movement of the body or the abdominal organs irritates the inflamed peritoneum, causing additional pain. To minimize this pain, patients will lie still, usually with their knees drawn up. Breathing will be rapid and shallow. Sample history. Use OPQRST to help explain an abdominal injury. Ask if the patient has experienced any nausea, vomiting, or diarrhea. How many times and over what period? Ask about the appearance of any bowel movements and urinary output. Determine if there was any blood in the urine or black tarry stools. This will help determine if the patient has gastrointestinal bleeding and if there is bleeding in the lower intestinal tract. Secondary assessment. may not have time to perform this detailed comprehensive exam in critically injured patients. Physical examinations. Remove or loosen clothing to expose injured regions of the body. Inspect the patient for bleeding before removing the clothing to prevent damaging exposed tissues. Provide privacy or perform in the back of an ambulance. Patient should be able to stay in a position of comfort unless spinal injury is suspected. Will relieve some of the tension. Place padding under the knees of the patient with a suspected spine injury. Can worsen pain if you are too aggressive. Fetal position may be the position of most comfort for a pain without spinal injury. Examine the entire abdomen, including all posterior, anterior, and lateral surfaces. Critical step for patients with an entrance wound. Use DCAP BTLS to help identify specific signs and symptoms of injury. Inspect and palpitate the abdomen for the presence of deformities. Look for the presence of contusions and abrasions. Puncture wounds and other penetrating injuries cannot be overlooked. The intra-abdominal extent of these injuries may be life-threatening. Note the presence of burns, palpitate for tenderness, and attempt to localize to a specific quadrant of the abdomen. Treat lacerations with appropriate dressing. Swelling may involve the abdomen globally and indicate significant internal abdominal injury. Palpate the abdomen when examining the region. Palpate the quadrant furthest away from the quadrant that exhibiting signs and symptoms of injury and pain. This technique allows you to investigate the possibility of radiation and extension of the pain into other quadrants. Perform a full body scan to identify injuries and other than abdominal injuries. Begin with the head and finish with the lower extremities, moving in a systematic manner. Goal is to identify the presence of other injuries, not the extent of those injuries. If you find a life-threatening issue, stop and treat it immediately. Assess the patient's need for spinal immobilization and apply per local protocol. Inspect and palpate the kidney area for tenderness, bruising, swelling, and other signs of trauma. Hollow organs will spill their contents into the peritoneal cavity. Those injuries will typically present as diffuse pain with guarding and reaction to sudden jarring movements. Obtain vital signs. Many abdominal emergencies can cause a rapid pulse and low blood pressure. Your record of vital signs will help you identify changes in the patient's condition. Use appropriate monitoring devices when available. Pulse oximetry, non-invasive blood pressure devices. It is recommended that you always assess the patient's first blood pressure manually with a spirometer and a stethoscope. If the MOI suggests that an isolated injury to the abdomen, focus your physical examination on the injured area only. Inspect the skin of the abdomen for wounds through which bullets, knives, or other missile-type foreign bodies may have passed. If you find an entry wound, you must always check for a corresponding exit wound. Do not attempt to remove a knife or other impaled objects. Instead, stabilize the object with supportive bandaging. Reassessment. Repeat the primary assessment and vital signs. Reassess the interventions and treatment you have provided. Interventions. Manage airway and breathing problems based on signs and symptoms found during the primary assessment. Provide complete spinal immobilization to the patient with suspected spinal injuries. If the patient has signs of hypoperfusion, provide aggressive treatment for shock and rapid transport. If an evisceration is found, place a saline moistened dressing over the wound and transport. Never attempt to push eviscerated tissue or organs back into the abdominal cavity. A patient with a ruptured diaphragm may have an abdomen with a sunken anterior wall. These patients should receive positive pressure ventilations with a bag valve mask. Communication and documentation. Communicate all relevant information to staff at the receiving hospital. Document the results of the physical examination and any pertinent negatives. It is important that you be able to describe the scene in enough detail to give the trauma team a clear idea of the circumstances. Be cautious and diligent when dealing with patients who refuse transport after sustaining an injury to the abdomen or genitourinary system. These patients are high risk for complications. Emergency medical care of abdominal injuries. Closed abdominal injuries. The EMT's biggest concern is not knowing the true extent of a closed abdominal injury. A patient requires rapid transport to the nearest and highest level of care, primarily to a trauma center with a surgeon. Position the patient for comfort. Apply high-flow oxygen if the patient has signs of hypoxia or shock. Treat for shock. Patient with blunt abdominal wounds may have severe bruising of the abdominal wall, liver and spleen laceration, ruptured intestines, tears to the mesentery, rupture of kidneys or avulsions of the kidneys from their arteries and veins, rupture of the urinary bladder, severe intra-abdominal hemorrhage, and peritoneal irritation and inflammation. A patient with blunt abdominal injury should be log rolled to a supine position on a backboard. Protect the spine. Monitor the patient's vital signs for any indication of shock and treatment appropriately. Open abdominal wounds. Patients with penetrating injuries generally obvious wounds and external bleeding. However, significant external bleeding is not always present. Maintain a high index of suspicion for serious unseen blood loss. Only a surgeon can accurately assess the damage. You should assume the object has penetrated the peritoneum and possibly injured organs. Follow the general procedures described previously for the care of a blunt abdominal injury, as well as inspect the patient's back and sides for an exit wound. Apply a dry, sterile dressing to all open wounds. If the penetrating object is still in place, apply a stabilizing bandage around it to control external bleeding and minimize movement of the object. Severe lacerations of the abdominal wall may result in evisceration. Internal organs or fat protrude from the wound. Never try to replace a protruding organ. Keep the organs moist and warm. Cover the wound with moistened, sterile dressings. Secure the dressing with a bandage. Secure the bandage with tape. These figures show the step to apply a dressing to an open abdominal injury. Anatomy of the genitourinary system. The genitourinary system controls reproductive functions and waste discharge. Organs of the genitourinary system are located in the abdomen. Kidneys are solid organs. Ureters, bladder, and urethra are solid organs. The genital system controls reproductive processes. The male genitalia lie outside the pelvic cavity except for the prostate gland and seminal vesicles. The female genitalia are contained entirely within the pelvis except for the vulva, clitoris, and labia. The figure shows the organs of the male reproductive system. The figure shows the organs of the female reproductive system. Injuries to the genitourinary system. Kidney injuries. Not unusual or rarely occur in isolation. A forceful blow or penetrating injury is often involved. Less significant injuries can result from an indirect blow or even a football tackle. Suspect kidney damage if the patient has a history or physical evidence of any of the following: an abrasion, laceration, or contusion on the flank, a penetrating wound in the region of the lower rib cage and above the hip, flank, or the upper abdomen, fractures on either side of the lower rib cage or the lower thoracic or upper lumbar vertebrae, a hematoma in the flank region. Urinary bladder injuries may result in rupture, urine spills into the surrounding tissues. Blunt injuries to the lower abdomen or pelvis can cause rupture to the urinary bladder, particularly when the bladder is full and distended. Penetrating wounds of the lower mid-abdomen, or the peritoneum can directly involve the urinary bladder. In males, sudden deceleration from a motor vehicle or motorcycle crash can shear the bladder from the urethra. In later trimesters of pregnancy, the bladder injuries increase from displacement of the uterus. This figure shows how a fracture of the pelvis can result in the perforation of the bladder. External male genitalia injuries, soft tissue wounds, painful and of great concern for the patient, but rarely life-threatening. Should not be given priority over more severe wounds unless there is significant bleeding. Female genitalia injuries, internal female genitalia. The uterus, ovaries, and fallopian tubes are rarely damaged. Small, deep in the pelvis and well protected. Exception in the pregnant uterus. Uterus enlarges substantially and rises out of the pelvis. Injuries can be serious because the uterus has a rich blood supply during pregnancy. Also keep the fetus in mind. In the last trimester of pregnancy, the uterus is large and may obstruct the vena cava. Blood pressure may decrease. Patient should be placed on her left side so the uterus will not lie on the vena cava. External female genitalia includes the vulva, clitoris, and major and minor labia at the entrance of the vagina. Very rich nerve supply, so injuries are very painful. Vaginal bleeding may occur because of penetrating or blunt trauma. Consider sexual assault in pregnancy. Ask the patient about the last known menstrual period. Ask about sexual history. Assume all women of childbearing age are possibly pregnant. This information is relevant because some medications and tests are harmful for a fetus. In cases of external bleeding and trauma, a sterile, absorbent sanitary napkin or pad may be applied to the labia. Do not insert instruments, gloved fingers, or tampon into the vagina. This can cause further damage. A patient assessment of the genitourinary system. Potential for patient embarrassment. Maintain a professional presence. Provide privacy during the assessment. When possible, have an EMT of the same gender perform the assessment. Look for blood on the patient's undergarments and only inspect the external genitalia when there are complaints of pain or external signs of injury. Scene size up. Assess a scene for hazards and threats to the crew safety. Assess the impact of hazards on patient care. At minimum, gloves and eye protection are required. Minimize your direct contact with bodily fluids. Blood can be hidden under thick layers of clothing. Mechanism of injury and nature of illness. Look for indicators of the MOI. Consider information from dispatch, your observations of the scene, and the MOI to help develop your list of expected injuries. Patient may avoid the discussion to avoid undergoing a physical examination. Patient may also provide an MOI that seems less embarrassing than the actual MOI. Primary assessment. Quickly scan the patient to identify and treat life threats. Genitourinary system is very vascular. Injuries can produce a significant volume of blood. Do not avoid this area in the rapid scan. Life-threatening hemorrhage can be addressed immediately. If bleeding is present, maintain privacy for the patient and inspect exterior genitals for visible injury. Form a general impression. Airway and breathing. Ensure that the patient has a clear and patent airway. Protect the patient from further spinal injury if trauma is involved. If the patient is unresponsive or has a significant altered level of consciousness, consider inserting an oropharyngeal airway or a nasopharyngeal airway. Circulation. Genitourinary system can be a significant source of bleeding. Assess pulse rate and quality. Determine skin condition, color, and temperature. Check capillary refill time. Closed injuries do not have visible signs of bleeding. Shock may be present. Assess of pulse and skins will indicate how aggressively to treat for shock. Control bleeding if visible. Bleeding is seen. Significant bleeding is a life threat and must be controlled quickly. Transport decision. Any injury to the genitourinary system can be life-altering, often requires medical specialists for specialized care. History taking. Investigate chief complaint. Common associated complaints with genital urinary injuries are nausea and vomiting, diarrhea, blood in urine, vomiting blood, abnormal bowel or bladder habits. Sample history. Use OPQRST to learn about the patient's pain. Ask the patient about output from the genital urinary system, especially blood and urine. Ask about allergies to medications or environmental triggers. The importance of past medical history cannot be overstated. Repeat or previous injuries or illnesses can help determine the extent of the current injury or illness. Last intake of food and fluids is important because it can predict the genital urinary system's contents. Address the events leading up to the injury. Secondary assessment. Physical examinations. Genital urinary system injuries can be awkward to assess and treat. Privacy is a genuine concern. When the patient has an isolated injury, focus on that and the body region affected. Look for decap BTLS. Identify wounds and control bleeding. For significant trauma, start with a full body scan to see if the trauma affecting multiple systems. Presence of penetrating injury indicates possible internal injury that should be managed accordingly. Presence of burns must be noted and managed immediately. Palpate for tenderness and localize the injury and presence of fractures. Look for lacerations and local swelling. Vital signs. Obtain the patient's vital signs. It is important to reassess vital signs to identify how quickly the patient's condition is changing. Signs such as tachycardia, tachypnea, low blood pressure, weak pulse, and cool, moist, and pale skin indicate hypoperfusion. Evaluate the need for rapid transport. Use pulse oximetry and non-invasive blood pressure devices when available. Reassessment. Repeat the primary assessment and vital signs. Reassess the interventions and treatment you have provided. Interventions. Provide oxygen if there are signs of dyspnea or shock and maintain a patent airway. Attempt to control bleeding and treat for shock. Place patient in position of comfort and transport. Communication and documentation. Communicate your concerns to the hospital staff. Describe all the injuries and treatment given. Documentation should be complete and thorough. Emergency medical care for genital urinary injuries. Kidneys. Damage may not be obvious upon inspection. However, you will see signs of shock, blood in the urine. Treat for shock, transport promptly, and monitor vital signs en route to the hospital. Urinary bladder. Suspect a urinary bladder injury if you see blood at the urethral opening, signs of trauma to the lower abdomen, pelvis, or perineum. If shock or associated injuries are present, transport promptly and monitor vital signs en route. External male genitalia. A few general rules for treatment of injuries to the external male genitalia. Injuries are painful. Make the patient comfortable. Use sterile, moist compresses to cover areas stripped of skin. Apply direct pressure with dry, sterile gauze dressings to control bleeding. Never move or manipulate foreign objects in the urethra. Identify and take avulsed parts to the hospital with the patient. If the patient has an avulsion of skin on the penis, wrap the penis in a soft, sterile dressing moistened with sterile saline. Transport promptly. Use direct pressure to control any bleeding. Try to save and preserve the avulsed skin. Amputation of the penile shaft. Managing blood loss is a top priority. Use local pressure with a sterile dressing on the remaining stump. Never apply a constricting device. Surgical reconstruction is possible if you can locate the amputated part. Wrap in a moist, sterile dressing. Place it in a bag. Transport in a cooled container without it directly touching ice. If the connective tissue surrounding the erectile tissue is severely damaged, the shaft can be fractured or severely angled, sometimes requires surgical repair. Injury may occur during practically active sexual intercourse, associate with intense pain, bleeding in the tissues, and fear. Accidental laceration of the head of the penis is associated with heavy bleeding. Local pressure with a sterile dressing usually stops the hemorrhage. Skin of the shaft or foreskin can get caught in the zipper of pants. Not uncommon event. If small segment of the zipper is involved, you can try to unzip the pants. If a longer segment is involved, use heavy scissors to cut the zipper out of the pants to make the patient more comfortable. Explain what you are going to be cutting. Be careful not to injure the scrotum while cutting. Urethral injuries in the male are not uncommon. Lacerations of the urethra can result from stratal injuries, pelvic fractures, penetrating wounds of the perineum. It is important to know if the patient can urinate and if there is blood in the urine. Save any urination for later examination at the hospital. Any foreign bodies protruding from the urethra will have to be surgically removed. Avulsions of skin of the scrotum may damage the scrotal contents. Preserve the avulsed skin in a moist, sterile dressing for possible use in reconstruction. Wrap the scrotal contents or the perineal area with a sterile, moist compress and use a local pressure dressing to control bleeding. Direct blows to the scrotum can result in rupture of testicle or significant accumulation of blood around the testes. Apply an ice pack to the scrotal area during transport. Female genitalia. Treat lacerations, abrasions, and avulsions with moist, sterile compress. Use local pressure to control bleeding. Hold dressings in place with a diaper-type bandage. Do not pack dressings into the vagina. Leave any foreign bodies in place after stabilizing with bandages. Injuries are painful but generally not life-threatening. In-hospital evaluation required. Transport urgently is determined by associated injuries, the amount of hemorrhage, and the presence of shock. Rectal bleeding. Common complaint. Bleeding from the rectum may be present as blood in or soaked through undergarments, or may be passed into the toilet with a bowel movement. Possible causes include sexual assault, rectal foreign bodies, hemorrhoids, colitis, and ulcers in the digestive tract. Significant rectal bleeding can occur after hemorrhoid surgery. Can lead to significant blood loss and shock. Sexual assault. Sexual assault and rape are all too common. Victims are generally women. Sometimes men and children are victims. Often there is little that you can do beyond providing compassion and transport. The patient may have sustained multi-system trauma and need treatment for shock. Do not examine the genitalia unless obvious bleeding requires application of a dressing. Follow appropriate procedures and protocol. Shield the patient from curious onlookers. Document the patient's history, assessment, treatment, and response to the treatment for possible court appearances. Do not speculate. Record only the facts. Follow any crime scene policy for your EMS system. Advise the patients not to wash, bathe, shower, douche, urinate, or disinfect until after a physical examination. If oral penetration occurred, advise the patient not to eat, drink, brush teeth, or use mouthwash until after a physical examination. Handle the patient's clothing as little as possible. Place articles of clothing or other evidence in paper bags. Do not use plastic bags because mold can grow and destroy evidence. Make sure the EMT caring for the patient is of the same gender as the patient whenever possible. Treat medical injuries and provide privacy, support, and reassurance. Okay, class, let's go over some review questions. Review question 1. Peritonitis would most likely result following injury to the A. liver, B. spleen, C. Kidney, D. Stomach. The correct answer is D. In general, solid organs bleed when injured, and hollow organs spill their contents into the abdominal cavity, resulting in peritonitis, inflammation of the abdominal lining. Of the choices listed, the stomach is the only hollow organ. Liver. The liver typically bleeds into the abdominal cavity. The spleen typically bleeds into the abdominal cavity, although the spleen does hold bile contents, so it can irritate the intro lining of the abdominal cavity. Kidneys. The kidneys typically bleed into the retroperitoneal space and not into the abdomen. D is the correct answer. Review question 2. Which of the following organs would be the most likely to bleed profusely if severely injured? A. Liver, B. Kidney, C. Stomach, D. Gallbladder. The correct answer is A. The liver is a highly vascular solid organ and contains approximately 40% of the body's total blood volume at any given time. If severely injured, bleeding from the liver would be profuse and rapid. Other solid organs such as the spleen and kidneys may also produce severe bleeding if injured, though not as rapid as the liver. The stomach and gallbladder are hollow organs, and if lacerated, they would spill their contents into the abdominal cavity, resulting in peritonitis. The liver is the correct answer. B. The kidney will produce bleeding, but not as rapidly as the liver. The stomach and gallbladder are both hollow organs and will spill their contents into the abdominal cavity. Review question 3. Which of the following statements regarding intra-abdominal bleeding is false? A. Intra-abdominal bleeding often causes abdominal distension. B. Intra-abdominal bleeding is common following blunt force trauma. C. The absence of pain and tenderness rule out intra-abdominal bleeding. Bruising may not occur immediately following blunt abdominal trauma. The correct answer is C. Intra-abdominal bleeding is common following blunt trauma to the abdomen. Signs including abdominal distension, rigidity, bruising may not occur immediately, and in some cases pain to palpitation. However, unlike gastric juices and bacteria, blood within the abdominal cavity does not provoke an inflammatory response. Therefore, the absence of pain and tenderness does not rule out internal bleeding. Answer A. You may see evidence of this of abdominal distension. B. This is common condition following blunt trauma. The correct answer is C. D. This may not occur immediately. Review question 4. Even when seatbelts are worn properly and the airbags deploy, injury may occur to the A. Chest, B. Extremities, C. Iliac crests, D. Lower rib cage. The correct answer is C. Seatbelts should be positioned over the iliac crest of the pelvis. If they are positioned higher, significant intra-abdominal injury can occur. Even when seatbelts are properly positioned and airbags deploy, the injury to the iliac crest may occur as the locking mechanism of the seatbelt engages during a motor vehicle crash that involves rapid deceleration. A. If the seatbelts are worn too high, the abdominal injuries may occur. B. The extremities are not likely to be injured if seatbelts are worn properly. C is the correct answer. D. If seatbelts are worn too high, then abdominal injuries may occur. Review question 5. While inspecting the interior of a wrecked automobile, you should be most suspicious that the driver experienced an abdominal injury if you find A. A deformed steering wheel, B. The airbags deployed, C. A crushed instrument panel, D. Damage to the lower dashboard. The correct answer is A. Airbags save lives when used in conjunction with properly worn seatbelts. Unfortunately, however, not all drivers wear their seatbelts. If unrestrained, the driver's abdomen may strike the steering wheel, resulting in significant trauma. Suspect this if you lift the airbag and note the lower part of the steering wheel is deformed. A is the correct answer. B. Typically the face and chest are impacted by the airbags. if safety belts are worn properly. C. This would indicate the possibility of leg and hip injuries. D. This would indicate the possibility of leg and hip injuries as well. Review question 6. Other than applying a moist sterile dressing covered with a dry dressing to treat an abdominal evisceration, an alternate form of management may include A. Placing dry paper towels over the open wound, B. Cleaning the exposed bowel with sterile saline, applying a PASG to stop the associated bleeding, applying an occlusive dressing secured by trauma dressings. The correct answer is D. Although the preferred management for abdominal evisceration includes the application of a moist sterile dressing covered by a dry dressing, protocols in some EMS systems call for an occlusive dressing secured by trauma dressings. An occlusive dressing may help prevent the loss of body heat through the abdominal wound. A. Treatment is a moist sterile dressing over an open wound. B. EMS should not clean any exposed abdominal organs. C. PASG inflammation is contraindicated with abdominal evisceration. D is the correct answer. Review question 7. You are transporting a patient with possible peritonitis following trauma to the abdomen. Which position will he most likely prefer to assume? A. Sitting up. B. Legs drawn up. C. Legs outstretched. D. On his right side. The correct answer is B. Patients with peritonitis often lie very still and tend to have their legs drawn up into their abdomen. This relieves strain on the abdominal muscles and may provide pain relief. A. Laying very still with the legs drawn up to help relieve the patient's pain. B is the correct answer. Legs outstretched would more than likely make it more painful for the patient. And D, the patient's legs drawn up or flexed to help relieve pain. Review question 8. A 16-year-old boy was playing football and was struck in the left flank during a tackle. His vital signs are stable, however, he is in severe pain. You should be most concerned that he has an injury to his A. liver, B. spleen, C. kidney, D. bladder. The correct answer is C. The flanks are located laterally on the back and overlap with the kidneys. During football, spearing injuries can occur when a player is struck in the flank by another player's helmet. This can result in injury to the kidney, ranging from bruising to severe bleeding. Injury to the liver, spleen, and bladder would more likely occur following blunt trauma to the anterior abdomen. A. The liver is associated with an injury to the anterior abdomen and right upper quadrant. Spleen is also associated with an injury to anterior abdomen and left upper quadrant. C is the correct answer. D. The bladder is associated with injury to the anterior abdomen and midline in the lower quadrants. Review question 9. The term hematura is defined as A. Blood in the stool, B. Blood in the urine, C. Vomiting up blood, or D. Urinary bladder rupture. The correct answer is B. Blood in the urine is called hematura. Following trauma, the presence of hematura suggests injury to the urinary bladder or kidneys. Bright red blood in the stool is called hematochezia. Dark tarry stools are called melena. Vomiting up blood is called hemiomesis. A. This is known as hematochezia or melena. B is the correct answer. C. Vomiting up blood is known as hemiomesis. Urinary bladder rupture. This will produce abdominal pain and eventually peritonitis due to the leaking into the abdominal cavity. It will also cause a lack of or reduction of urinary output. Review question 10. When caring for a female with trauma to the external genitalia, the EMT should A. Use local pressure to control bleeding. B. Carefully pack the vagina to reduce bleeding. C. Remove any impaled objects from the vagina. D. Cover any open wounds with moist sterile dressings. The correct answer is B. A. Bleeding from the external genitalia should be controlled by applying a dry, sterile dressing and local direct pressure. Never pack anything into the vagina to try to control bleeding. This increases the risk of infection, and anything you place into the vagina will only need to be removed at the hospital. Impaled objects in the genitalia should be carefully stabilized in place, not removed. A is the correct answer. B, never pack anything into the vagina. C, impaled objects are stabilized in place and not removed. D, apply dry, sterile dressings with local direct pressure. Okay, class, this concludes the lecture on Chapter 30, Abdominal and Genitourinary Injuries. If you have any concerns or questions, please contact your instructors, and I'll see you in the next chapter.